So there are toxicities associated with the use of these non-sympathomimetic agents. These non-specific sympathomimetic agents. So your epinephrine, the effect is a rapid bronchodilator. So for example, if someone suffers a severe allergic reaction and they cannot breathe, if you inject epinephrine intramuscularly, then the response of bronchodilation is very fast. But take note, it has serious side effects. So the patient may have arrhythmias and tachycardia. So the use is very limited. Another drug, we have your ephedrine. It has a longer duration and oral activity, but it is less potent. What do we mean when we say less potent?
Lesser effect, ma'am.
Lesser effect. Yes, anybody else? What do we mean when we say it is less potent?
Lesser concentrated.
Can
The
you
strength, ma'am.
Can you expound on that? Maybe you raise your hand and then how do I see the participants raising their hands? Michelle Fabro. Yes, ma'am, Michelle, go ahead.
Less potent, ma'am, it means that there's a lower degree of strength or effectiveness on the concentration.
Okay. I want to hear Lian Sanchez. I cannot hear you.
Yes, no problem. I think less potent, meaning with lesser concentration of that drug, it can achieve the whatever effect that you want.
I think what you're trying to describe is a more potent drug. So,
okay.
But thank you for answering. So let's discuss potency. When we talk about potency, it does not mean that the drug does not achieve the desired effect. We're not talking about that. What we're talking about is the dosage. You're right, the dosage and concentration of the drug for it to achieve the therapeutic effect that we want. So if we say that a drug is more potent, even if we give a very low dosage of that drug, it still can achieve the desired effect. So if we say less potent, it means you need to give more milligram of the drug before it can achieve the desired therapeutic effect. So when we talk about ephedrine, although it has a longer duration, it is less potent, meaning you need to give more dosage of the drug before it can achieve what you want to achieve for that particular effect. So I appreciate everyone who's participating on our discussions. So let's continue. When we say isoproterenol, this is a beta blocker, but it is a non-selective beta 1 and beta 2. No, not blocker, rather. It is a non-selective beta 1 and beta 2 bronchodilator. Your epinephrine and ephedrine, they both activate alpha and beta receptors. But when you talk about isoproterenol, they are non-selective beta 1 and beta 2 bronchodilator. So they are now not used because, or very rarely used because of cardiac arrhythmias. Now, the introduction of beta-2 selective agents have largely replaced epinephrine, ephedrine, and isoproterenol. Now, let's talk about your beta-2 selective drugs. So your albuterol, terbutaline, metaproterenol, and pirbuterol, they are all beta-2 selective drugs. They are short-acting. So we call them your SABA, short-acting beta agonists. Their effect is as fast as 15 minutes. So within 50 minutes, we expect that there is already bronchodilation, but this effect only lasts for a short time. So it only lasts 3 to 4 hours. Levalbuterol is an R isomer of albuterol, but it says in the book it has no proven efficacy or toxicity advantage over the racemic mixtures. Now, we also have what we call your LABA, your long-acting beta agonist. So examples of which are salmeterol and formoterol. So this LABA have a 12-hour effect. So we can give it twice a day or sometimes once a day, depending on the need of the patient. So it should be used, take note class, when we're using LABA, it should be used with corticosteroids and not as a monotherapy because it is more effective with inhaled corticosteroids. Now, when we're talking about LABA or SABA, aside from being given orally or via nebulization, there are also what we call your metered dose inhalers. So let me just share with you. This video. I'm not sure if I was able to choose. I'm not sure if I was able to choose the option where you can hear it. Can you hear it?
Hindi po, Doktor.
No po. No po.
Oh. Okay, let me just stop sharing and then reshare.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk. What was that all about?
Jamaican chicken recipes.
All right. So I wanted to share that with you, although I believe some of you or majority of you have already seen that. But I would like to give emphasis that though we are giving the correct medication or dosage of the medication, if it is not properly demonstrated, especially on the use of these inhalers, it will not be effective. So I will be sharing with you a video later on how we could properly teach our patients to use these inhalers. So before we move on to that video, we have what we call your ultra long acting beta agonist. So this includes your indacaterol and bilanterol. So because they are ultra long acting, you only need to take it once a day. But take note, it should also be combined with inhaled corticosteroids, especially for using it for asthma treatment to avoid masking inflammation symptoms. So with that, I'm going to share with you a video of, it's a health education video, very much available in YouTube on how we're going to teach our patients to use Breeze Haler. So this contains a long-acting beta agonist with sometimes there are inhalers already containing LABA, LAMA, and ICS. So your long-acting beta agonist, your long-acting muscarinic antagonist, and your inhaled corticosteroid. So let's watch this video.
Ito naman ang tinatawag na breeze haler. Ang halimbawa nito ay Seabree at Anbres. Ganito ang tamang paggamit. Iangat at tanggalin ang takip. Hawak ang ilalim, iangat ang mouthpiece para mabuksan ang breeze haler. Ihanda ang kapsula, pirasuhin ang pakete na kinalalagyan nito, iangat ang takip para mailabas ang kapsula. Ilagay ang kapsula sa butas. Pagkatapos ay isara ito hanggang may marinig na click. Habang hawak ng patayo ang breeze hailer, pindutin papaloob minsan ang dekolor na parte para mabutas ang kapsula sa loob. May maririnig kang click at bitiwan uli ito. Huminga ng papalabas ng malayo sa breeze hailer. Iangat ng kaunti ang ulo, ilagay sa bibig ang mouthpiece, huminga ng malalim at mabagal. Maririnig mong tumutunog ang laman ng kapsula sa loob at may malalasahan kang matamis bilang tanda na pumapasok na ang gamot sa iyong baga. Tanggalin ang breeze hailer, magpigil hinga ng 5 hanggang 10 segundo, pagkatapos ay huminga ng papalabas. Para makasigurong nakuha lahat ang laman ng kapsula ng breeze hailer, ulitin ang paglagay ng breeze hailer sa bibig, huminga ng mabagal at malalim hanggang mapuno ang baga, tanggalin ang breeze hailer, magpigil hinga ng 5 hanggang 10 segundo, at huminga ng papalabas. Pag natapos na, iangat ang mouthpiece. Para mabuksan ang breeze hailer, itapon ang natitirang kapsula sa basura, isara ang breeze hailer, ibalik ang takip, maghugas ng kamay at iwasang maipahid sa mata ang laman ng kapsula. Ganito ang tamang paggamit ng iyong breeze hailer. Ito ang mga dapat mong tandaan sa paggamit ng iyong breeze hailer. Huwag lununukin ang mga kapsula. Tanggalin lamang ang kapsula sa lalagyan kapag handa nang gamitin ito. Huwag pipindutin ang dekolor na parte ng breeze hailer ng higit sa minsan sa bawat paggamit nito. Panatilihing laging tuyo ang iyong breeze hailer. Kung kailangang linisan, gumamit lang ng tuyong tela o ng tissue.
All right, so I hope that if we haven't mastered how to educate our patients in using properly our inhalers or those inhalers with spacers or these breeze healers, we should orient ourselves on this because it's very important that the means of delivering the medication is properly achieved in order for us to achieve as well the therapeutic effects. Now, what are the toxicities and some concerns about your sympathomimetic agents? So we have been discussing about cardiac arrhythmias and tachycardia. We also have what we call your tachyphylaxis. So anyone who knows what tachyphylaxis mean? Anyone? To our dear nurses? Yes, Ma'am Tricia. Yes, Ma'am Tricia, go ahead.
Tachyphylaxis refers to a rapidly diminishing response to a drug or treatment following the initial administration po. And this can occur when the body quickly develops a tolerance to the effects of the particular medication.
That's right. So thank you so much, Ma'am Tricia. The difference of tolerance and tachyphylaxis is the amount of time it takes before they have a decreased response. So for example, a certain person is drinking alcohol for a very long time, and then there is an observed effect of decreased response to alcohol over a long period of time, say 10 years. So we call that tolerance. But when we talk about tachyphylaxis, over just a short period of time, even if we just introduce the medication for the first time, there's already an observed decrease in the response. So we call that tachyphylaxis. There is a rapid decrease in the response. So tachyphylaxis is one of the concerns. Treatment has been observed but does not significantly impact the efficacy of usual doses. Another concern would be genetic variations in beta 2 receptors. So these genetic variations may also influence the response of that person to the treatment. And concerns about worsened hypoxemia and cardiac arrhythmias during acute treatment with sympathomimetic agents have been largely dismissed. Okay, it has been largely dismissed. So on this diagram, why is it doing this? Yeah, for a while. So on this diagram, as you can see, this is where your beta agonist acts on. So it activates your adenylate cyclase, which then increases CAMP by it increases the rate of the synthesis of adenylyl cyclase by which then further increases your cyclic adenosine monophosphate. So your cyclic adenosine monophosphate then activates broncho or causes bronchodilation. So that is for our beta agonist. So in summary, class, these are the drugs used in asthma. Your short-acting beta agonists or your SABA are represented by your albuterol. So the it is given by aerosol inhalation, and there are several toxicities such as tremor, tachycardia, and overdose of albuterol may lead to arrhythmias. So it's not only indicated for asthma but for COPD as well. But this is a drug of choice in acute asthma bronchospasm. SABA, salmeterol on the other hand, it is used for the prevention of asthma exacerbation. So your LABA is not used for acute attacks. So it is used to prevent asthma exacerbation. So it is being given via aerosol inhalation, and the toxicity include tremor, tachycardia. We also have your epinephrine and isoproterenol, which we have mentioned to be non-selective beta-2 agonists. Now, let's move on to the next drug category used for the treatment of asthma. We call them methylxanthines. So this include your theophylline, theobromine, and caffeine. So they are found actually in tea, cocoa, and coffee. The usage of these drugs has declined because of their side effects, and particularly theophylline because it has a narrow therapeutic index. It requires blood level monitoring. When we say narrow therapeutic index, the range between the minimum effective dose and the minimum toxic dose is very narrow, such that only a slight increase in the dosage of the drug may already lead to overdosage, and a slight decrease in the dosage of the drug may lead to not achieving the desired therapeutic effect. And aside from that, it is not anymore used usually used because there are already better alternatives. So what is the mechanism of action of your methylxanthines? There are actually three mechanism of actions. First is that it inhibits your phosphodiesterase, it antagonizes your adenosine receptors, and it enhances histone deacetylation, which actually increases corticosteroid effectiveness. So there are three mechanism of actions. It is noteworthy to mention one of the methylxanthine drugs called your roflumilast. They are selective PDE4 inhibitors. They reduce inflammation, and they are approved for COPD but not for asthma. Now, going back to this diagram, we have here your theophylline. I mentioned earlier, yung mechanism of action niya is that it inhibits phosphodiesterase. So if it inhibits phosphodiesterase, it slows down the degradation of CAMP. So if you inhibit, because your phosphodiesterase enzyme degrades CAMP into your adenosine monophosphate. Now, if you inhibit your phosphodiesterase enzyme, then there will be decreased degradation of CAMP, which then lead to increases CAMP level, which will lead to bronchodilation. Aside from that, your theophylline also inhibits your adenosine receptors. And when we talk about adenosine, if they are not inhibited, this will lead to bronchoconstriction. But because we are inhibiting adenosine receptors, it will actually lead to bronchodilation. Now, for pharmacodynamics of methylxanthine, there are different effects. For the CNS, there is arousal because this comes from coffee, right? So when we drink coffee, we are mentally awake. So we are alert. But high doses of this methylxanthines can lead to seizures or convulsions. In the cardiovascular system, there is a positive chronotropic and inotropic effect. So when you say chronotropic effect, there is increase in the rate of the increase in heart rate. But when you say inotropic effect, increase in the strength or in the contractility of the heart. So this may lead to tachycardia and even arrhythmias, especially when given at high doses. On the GI, on the other hand, it stimulates the secretion of gastric acid and digestive enzymes. For the kidney, it causes a weak diuretic effect. And for the smooth muscle, this is the desired effect that we want. It leads to bronchodilation. Skeletal muscles, your methylxanthine improves contractility of the muscles and may alleviate dyspnea in COPD. So clinically, your theophylline is an effective bronchodilator, but it is no longer used commonly for asthma because of better alternatives and because of its side effects. So in summary, your theophylline, it is indicated for asthma and COPD. The oral duration is 8 to 12 hours. And there are multiple toxicities, which I have mentioned earlier. Okay, we're done with our beta agonists, your methylxanthines. We move on to another drug category, your anti-muscarinic agents. So when we talk about muscarinic, we're pertaining to muscarinic receptors. And when we talk about muscarinic receptors, these are for your parasympathetic nervous system. They are activated when acetylcholine is released in the synapse. So under this drug category, we have your atropine, which was actually discovered from a plant, your Datura stramonium. It is a competitive inhibitor of acetylcholine at the muscarinic receptors. Okay, and your ipratropium was actually developed from atropine. So they observed ipratropium to be a poorly absorbed atropine analog. So because it is a poorly absorbed analog, it minimizes the systemic side effects. So it minimizes the side effects when inhaled. All right. So if we take a look at this diagram earlier, your muscarinic antagonist inhibits your acetylcholine from binding to the muscarinic receptors. Therefore, instead of leading to bronchoconstriction, it actually leads to bronchodilation. Okay, it leads to bronchodilation. Okay, for a while, class, 2 minutes. All right. So their action is limited to the part of the bronchospasm mediated by muscarinic receptors. So clinically, we use them as bronchodilators, and your ipratropium is said to be comparable to the effect of your albuterol, which is a short-acting beta agonist, in the use for COPD patients. So it is beneficial if a patient cannot tolerate your beta agonist. We can use your antimuscarinic agent, your ipratropium. So we also know drug mixtures wherein it combines your short-acting beta agonist plus your short-acting muscarinic antagonist in the form of your salbutamol and ipratropium, right? What do we call the brand name of that drug combination?
Duavent po, no?
Yes.
Yeah,
Yes, that's
do a bit.
right. So
Convent.
yes, that's right. Thank you. So it's actually a mixture of your SABA and your SABA and your SAMA. All right. So next we have, if there is a short-acting muscarinic antagonist, we also have what we call your long-acting anti-muscarinic agents. So this will include your tiotropium, aclidinium, and umeclidinium. So when we talk about LAMA, you have to remember that these are mainly used for COPD. They are maintenance therapy for COPD. So they bind to M1, M2, and M3 receptors, but there is a faster dissociation from M2, which enhances their selectivity. So how long is the effect? Why do we call them long-acting? The tiotropium and umeclidinium have a 24-hour effect, while aclidinium lasts for 12 hours. So we may just give this to patient once or twice a day. Now, improve functional capacity and reduced exacerbation. This is what we target, particularly for COPD patients. That's why we give them LAMA. So they prevent exacerbations. So your LAMA, they are not yet approved for the treatment of asthma. So take note, they are used for COPD. Although your tiotropium is said to be as effective as your LABA when combined with ICS therapy. All right. Now, let's move on. What are ICS, or your inhaled corticosteroids? So your inhaled corticosteroids, your ICS or inhaled corticosteroids, they are used because of their anti-inflammatory property. So they reduce bronchial hyperactivity and the chronic response to asthma. So they also reduce vascular engorgement and they enhance beta agonist effects. Now, I have here an illustration from the book USMLE. So when we try to review the pathophysiology of your asthma, of course, exposure to antigen and allergen, dust or pollens, etc., is what activates. And when they have a cross-linking with your specific immunoglobulin E, it will cause your mast cells to degranulate, which then leads to the production of your pro-inflammatory mediators, such as your leukotrienes, histamines, and interleukins. Now, as you can see, there are two pathways. There is what we call your acute response. And on the acute response, there is bronchoconstriction. There is immediate bronchoconstriction. Now, when we talk about the chronic response, this now involves inflammation, okay? It involves inflammation. So we have your pro-inflammatory cytokines, which then causes your phospholipase A2 to cause the phospholipids to undergo the arachidonic acid pathway. So they can have the cyclooxygenase pathway or the lipoxygenase pathway. On the cyclooxygenase pathway, it will lead to the production of your prostaglandin, prostacyclin, and thromboxane, while on the lipoxygenase pathway, it leads to the production of leukotrienes, and your leukotrienes will then lead to, again, mucosecretion, plasma exudation, and eosinophil recruitment. Now, where do your corticosteroids act upon? They actually inhibit your phospholipase A2, such that your phospholipids will not undergo the different pathways. So here, it has already been inhibited on the root or on the base of that pathway. So your glucocorticosteroids are actually very effective in the treatment of asthma. Now, there are categories, two categories, your systemic glucocorticosteroids. They are very effective, but take note, they have significant adverse effects. Can you give me adverse effects that may be developed when a systemic glucocorticoid is used long term? Anyone? Let's see if someone is raising his or her hand.
Ma'am, hirsutism.
Hirsutism. What are more common adverse effects? Christine Angela Binasoy.
Doc, immunosuppression po.
Immunosuppression. So how does immunosuppression occur?
Doc, long-term use of glucocorticoids can suppress the immune system and increasing the risk of infection po, Doc.
Okay, so there's actually initially what we call your adrenal suppression. So your adrenal glands will, of course, there will be decreased production of your cortisol, even your mineralocorticoids, and even your sex hormones. Because of prolonged exposure to exogenous glucocorticoids. Aside from that, we also have what we call your Cushing syndrome. This is a condition wherein when the body is exposed to high levels of cortisol, there are manifestations, right? Such as your buffalo hump, there are discoloration of the skin, there is water retention. What else?
Glaucoma, ma'am.
Yes, actually, because of hyperglycemia.
Cataracts.
That's right. So in general, it will lead to hyperglycemia. It may also lead to dyslipidemia and even cardiovascular disease. So patients with long-term exposure to glucocorticoids may actually develop or may have heart attack, stroke, and other cardiovascular events. What else? They may also develop osteoporosis and psychiatric disturbances. And as mentioned earlier, immunosuppression. So the oral or parenteral use, we do not use that always. It is only reserved if the patient is in a severe status. So there's a need for urgent treatment. So if we cannot control the symptoms anymore, then we may use systemic glucocorticoids, but this is only for a certain period of time. So if there is urgent treatment needed, it may involve the use of oral prednisone, or we can give intravenously your methylprednisolone. Now, let's talk about your inhaled corticosteroids. So your ICS, such as your beclomethasone, budesonide, cyclesonide, flunisolide, fluticasone, mometasone, and triamcinolone, they are very important for the treatment of persistent asthma because it minimizes your systemic adverse effects. If it is inhaled, meaning the effect is direct on the lung tissues. So high doses are delivered to the airways, but there is minimal systemic absorption. Tapering for example, if we started the patient on oral steroid because of the acute exacerbation, we need to taper the oral steroids first before we start them with an inhaled corticosteroids to prevent the development of adrenal insufficiency. Now, what are the adverse effects of your inhaled corticosteroids? Take note, class, you said earlier immunosuppression. So since it's inhaled, meaning the areas where this corticosteroid will pass through before it reaches the lungs may also have the effect of the steroid, which is immunosuppression. Therefore, oropharyngeal candidiasis may be developed by these patients using inhaled corticosteroids. That's why in the video earlier, we heard her say that you should gargle water after inhalation to prevent oropharyngeal candidiasis. But say, for example, you already developed oropharyngeal candidiasis, then we may use clotrimazole, which is an antifungal topical treatment for management of your oropharyngeal candidiasis. Hoarseness of voice is also a direct effect of corticosteroids on the vocal cords. So So gargling with water will also help prevent this side effect. What else? Osteoporosis, cataracts, and in children, it may cause slow growth rate. Now, your corticosteroids are recommended for persistent asthma. The effects are not curative, take note, meaning if you stop using steroids, the symptoms of asthma may return. Intermittent use during symptom flare-up can be nearly as effective as daily use. So, how to use ICS according to our Cat Zoom book, they said we can use either use ICS with beta agonists on a daily basis, or we can use a short course of high-dose ICS when there is symptom exacerbation. But take note, these intermittent treatments, they are not officially endorsed by FDA. So in summary, we have your corticosteroids inhaled, your fluticasone, so asthma, adjunct in COPD. It is also used as an adjunct in COPD. The toxicity is limited by aerosol application, and candidial infection and vocal cord changes may occur. Prednisone, on the other hand, we have your fluticasone. There are multiple side effects which we already mentioned. Now, let's move on to the next category. We already talked about beta-2 agonists. We talked about methylxanthines. We talked about antimuscarinics. We talked about ICS. Now let's talk about your leukotriene antagonist. So your leukotriene antagonists under this category have your cromolyn and nidocramil, but these are no longer used. All right, but before they are used as an alternative to inhaled corticosteroids, particularly for patients with awakening at night because of asthma attacks. So they are no longer available in the US for asthma preparation, but there are other preparations with these drugs. So they may not be as effective as low-dose ICS, but they are preferred by some, particularly those who would like to avoid the side effects of your steroids. Now, since we do not have cromolyn and nidocramil anymore for asthma, we have what we call your Montelukast, which is under this category. So it is commonly prescribed by primary care providers. It is available oral medication, and the good thing is it has fewer adverse effects. So for patients with, or for children with asthma, they prefer this over corticosteroids. So your cromolyn and nidocramil, they are actually available as eye drops or nasal spray for allergic rhinitis. So this is your Montelukast. It is available as a 10 milligram tablet. Okay, so you have your leukotriene antagonists and your stabilizers of mast cells and other cells, such as your cromolyn, nidocramil, which are no longer available. So this is your stabilizers of mast and other cells. Now, what is an IgE antibody? Remember when we talked about the immunoglobulin E, which is released by your plasma cells? If we use an antibody against immunoglobulin E, this would mean it will prevent the degranulation of your mast cells. Okay, it will prevent the degranulation of your mast cells. So IgE antibody, the drug under this category is omalizumab. It prevents IgE from binding to the receptors on the mast cells and basophils. Therefore, it reduces allergic response. It will reduce bronchial inflammation. It will also help reduce steroid dosage and frequency of exacerbation and the severity of the exacerbations. Now, take note, when do we use this? We only use it if the patient with chronic severe asthma is no longer responding to your inhaled corticosteroids with LABA. We call this your targeted therapy for severe asthma. So it is also good for patients with IgE-mediated sensitivity and appropriate IgA levels administered bi-weekly via injection. So the thing about omalizumab is that it is expensive and not available in all areas. So we have right here the illustration from USMLE. You have your anti-IgE monoclonal therapy or your omalizumab. It inhibits your receptors for IgE. So if your immunoglobulin E cannot attach to its receptor, therefore it will not also cause the mast cells to release your pro-inflammatory cytokines. So you have your IgE antibody, your omalizumab. Now we also have what we call your anti-interleukin 5 pathway antibodies and other antibodies. So interleukin 5 drug categories under these are mepolizumab, benralizumab, and restrizumab. So they work against interleukin 5 and they are crucial for eosinophil activity in eosinophilic asthma. So just like omalizumab, we only use this if all else fails. All other treatments for severe persistent asthma has failed. So limitation, it is also very costly. It is given intravenously, and the potential adverse effects are rare anaphylaxis, arthralgias, fever, rash, infection rates, and possible new malignancies reported. So if you try to look at this diagram, this is where it takes effect. So IgE antibody will be more superior. It will be more superior because on this portion, it already prevented the release of your pro-inflammatory cytokines. While your anti-interleukin 5, it will have its effect on this level. Now, what are the limitations of your targeted therapy? Aside from high cost, there are risks of anaphylactic or hypersensitivity reactions. Your mepolizumab specifically increases the risk of herpes zoster. So patients receiving this drug is recommended to have varicella zoster vaccine, particularly those over 50 years old before starting the treatment. We also have your other anti-inflammatory therapies. These are for 5 to 10% of patients who do not respond to treatment. So we have a category of patients called as T2 low asthma patients, meaning they have low T helper 2 cells. So they are less responsive to targeted therapies such as your IgE antibody and your interleukin 5 inhibitors. So there are also other researches done, such as for your methotrexate or gold salt injections and cyclosporine, but they have not been too successful because they are toxic. All right. Now, when we talk about managing asthma, we need to know if it is a mild attack, a severe attack. And for mild attacks, we use your inhalational beta receptor agonist. Well, for severe attacks, we already need to use oxygen, aerosolized albuterol, and systemic steroids. Take note, class, systemic steroids such as your prednisone and methylprednisolone. Now, if all else fails, then we need to do intubation and mechanical ventilation. Now, in the hospital settings, we follow this diagram. For first, when the patient is admitted, we have to try to identify if it is a life-threatening asthma. If there are manifestations of drowsiness, if the patient is confused, or when you do auscultation, there is also already what we call your silent chest. So an urgent need to transfer to the ICU must be done. For a mild attack, what we do initially is we give salbutamol inhalation, 2.5 milligram per dose, by nebulizer every 20 minutes times 3 doses. Or if a nebulizer is not available, we can use a metered dose inhaler spacer, 4 puffs, and this course is repeated every 20 minutes times 3 doses. Now, if there is a good response, we just need to observe the patient for 3 or more hours. And if the patient is stable and there are no further attacks, we can discharge the patient and give inhaled or oral salbutamol every 6 hours. Now, if there is incomplete or poor response, we can already add steroids. And again, observe the patient for 4 hours, but still we continue nebulization every 4 to 6 hours. If improved, then we can discharge the patient. Upon discharge, we can continue your inhaled or oral salbutamol every 6 hours, and the steroids may be continued for 3 to 5 days and can be stopped without tapering. So if we only give the patient steroids for a few days, we don't need to taper it after. Now, if there is still poor response, then we can repeat the initial treatment as before. If general danger signs and difficulty breathing is presented, we can use ipratropium bromide, which is an antimuscarinic. Via inhalation, we can give oxygen and oral prednisone 1 to 2 milligram per kilogram patient. Now, what if it is a moderate to severe attack? Take note, class. We can still use salbutamol inhalation, 2.5 milligram per dose every 20 minutes times 3 hours. If not, we can use salbutamol via metered dose inhaler spacer. Again, 4 puffs every 20 minutes times 3 doses. Or we can use adrenaline or epinephrine injection, 0.01 ml per kilogram every 20 minutes times 3. We also give oxygen, and we can start steroids, whether that's oral or IV steroids, depending on what the patient can tolerate. And depending on the state of consciousness of the patient. Of course, if the patient is unconscious, we give intravenous methylprednisolone. Now, we reassess every 30 to 60 minutes. If there is a poor response, we continue with a bronchodilator 1 to 2 hourly and ipratropium 8 hourly, and give 1 dose of magnesium sulfate, and then reassess after every 30 to 60 minutes. If there is still a poor response, we can give aminophylline, and we can refer to a higher center if there is no response. Now, if there is a good response, take note of this principle, class. Last in, first out. So we omit the last drug to be added. Example, if it's aminophylline, then we omit aminophylline, followed by omitting ipratropium, and then reduce salbutamol inhalation, and then plan for discharge. Okay, it's a very long diagram, but I want you as nurses to be able to understand also this diagram so that we can understand the treatment being ordered by the doctors. So prevention, take note, class. How do we prevent this? So as nurses, we also have to understand this. Take note, class, according to the recent researches, early strict antigens avoidance is ineffective. We actually need to expose our children to some farm animals and even household pets because they will offer protection, because they may develop protection against this when they are exposed. But take note, if you know that there is a genetic predisposition. Halimbawa, in your family, there are a lot with asthma. We do not do this by flooding, which means you expose the child to a lot of allergen because this may lead to severe anaphylactic or severe asthma attack. We do this with gradual, right? Gradual exposure. Prevention may involve promoting a balanced immune response through early life exposure to microbial commensals. And then research is focused on identifying specific microbes or their products that support proper immune system development. Now, question, for quick symptom relief of all asthmatic patients, what treatment should be given?
Doc, salbutamol, short acting.
So we give for any type of asthmatic patients, whether they're mild or a moderate to severe attack, we need to give a short-acting beta agonist. So a SABA. Okay, albuterol or your salbutamol can be given. Very good. Now, this is the guideline for the treatment of asthma in all asthmatic patients. So there are different classifications. We grade our patients according to the symptoms. How many bronchoconstrictive episodes do they have in a week or daily? How many nighttime symptoms do they experience in a month? What is the result of their peak flow or spirometry? So we identify, basing on the classification, what are long-term controls and quick relief symptoms. As you can see on this column, it all includes a SABA, short-acting beta agonist. Okay, so for let's start with the most severe. So a grade 4 patient, which is severe persistent, has continuous bronchoconstrictive episodes, which actually leads to limited physical activity. They have frequent nighttime symptoms, and their forced expiratory volume 1 is less than 60% of normal. Now, for quick relief symptoms, example, if there is an acute exacerbation, we give short-acting beta agonist and ICS, and for Moterol, which is a LABA, is an alternative. While for prevention or long-term control, we give a medium dose ICS plus LABA or high dose ICS plus LABA. Now, for grade 3 moderate persistent, they have bronchoconstrictive episodes more than once a day, and then nighttime symptoms or nighttime awakening once a week. Their FEV1 is 60 to 80%. So we have, for quick relief, we have your short-acting beta agonist, ICS, and for Moterol is also an alternative. For long-term control, we have low-dose ICS plus LABA or medium-dose ICS on its own. For grade 2 mild persistent patient, their bronchoconstrictive episodes are more than one time a week, but less than once a day. Okay? And they have more than 2 times a month. So a controller could be just a low dose ICS. And for quick relief, we use SABA. For grade 1 who is mild intermittent, take note class, they are asymptomatic actually. In between attacks, they're asymptomatic, and then less than 2 times a month. The FEV1 is 80% normal. You don't need a daily medication for long-term control. You just need a SABA when there is an acute exacerbation. Okay, so there is a step-up treatment that we do. Specifically, if a patient, for example, with asthma, has viral infection, we can do a short step-up for just 1 to 2 weeks and then adjust the dosage of the patient once the viral infection has resolved. Or, for example, after 3 months, the patient no longer had an attack, we can do step down of the medication. Okay? Now, another question, before step-up therapy, what should you check first? Anyone?
Doc, try lang.
Yeah, sure.
Patient's response to treatment.
Patient, bali Doc, yung patient response to the previous treatment.
Yes, actually, it is already given that they did not respond well to the previous treatment. So, what do you think should we check first before we step up? So, for example, a patient comes to the clinic, you're the nurse on duty. So, you would have initial history taking of the patient. And she or he told you that the treatment given to her or him was not effective. Should you immediately refer to the doctor for step-up treatment, or what are other things that you can ask the patient before we do a step-up treatment?
Doc, pwede po mag-dry.
Sure. Who is this?
This is Miss Ocampo, Doc.
Yes.
Doctor, maybe you can try peak flow meter, usually, Doc. Is that acceptable, Doc? Yung breathing po ng patient before to step up?
So you're saying we do diagnostic test? Tama?
Try lang po, Doc, kasi po having a daughter and a husband po na may asthma. So in and out po kasi kami sa hospital, Doc. Kaya very interesting yung topic na to. Nakikinig talaga kami, Doc.
Okay. Sige.
Opo.
So, we can actually do that because it will help monitor respiratory conditions, right? So we would like to check the lung function. But let's say that we already did that and nakita talaga natin na it's not taking effect yet. So what I'm trying to emphasize here actually is that before we step up the treatment, we need to check for compliance. It's like the patient of Dr. House earlier. The patient was not using the device properly, correct? So we have to check that is there proper use of the device? Is there adherence? So, nagrereklamo siya na hindi siya natitreat, pero hindi pala siya nag-adhere sa treatment. Kasi sometimes, may nafe-feel siyang symptoms but did not tell us that they stopped the treatment. Or, even if they are using the device properly and they are being very compliant, but there are actually triggers. So they have a new pet or they didn't know that that is actually a trigger, for example, for whatever maybe the trigger. Kahit na magbigay tayo ng proper dosage and we use the device correctly, if there are triggers, so hindi natin yun ma-address. So that's what I'm trying to derive at. So thank you for those who answered, no? But that is what we do before we step up the therapy. We should check it first. Okay? So now I think that is all for asthma. My next slide would show us how COPD is managed. So just very briefly, when we talk about COPD, it's actually the third leading cause of death in the US, so according to the Katsung book. And the difference is that the obstruction for COPD as compared to asthma is that it is not fully reversible, unlike asthma. So it is a progressive disorder, which is caused by exposure to cigarette smoke and exposure to other noxious particles. So we have here an X-ray of a patient with emphysema. We can see there is a flattened diaphragm. There is increased spaces in between the ribs. That means there's hyperinflation and increased lucency and size of apices, the rectangle-shaped thorax instead of a triangle-shaped thorax. So when we talk about COPD management, there are similarities and differences with asthma. What I want to emphasize here is that for COPD patients, they are less responsive to inhaled corticosteroids. But we use your inhaled corticosteroids, especially for patients with COPD who have frequent and recurrent exacerbations. That is when we use the ICS. So acute symptom relief and long-term management for acute COPD symptoms, what do we use? Just like asthma, we also use your SABA and your anticholinergic drugs. Now, for persistent symptoms, we use your LABA or your LAMA. So your theophylline and roflumilast, they are both phosphodiesterase inhibitors, and they are treatments that are used for COPD because they help improve pulmonary function and reduce exacerbations. So as I mentioned earlier, your ICS is only used if there is severe airflow obstruction and recurrent history of exacerbations. Now, how do we manage stable COPD? I want you to take note of this. It is also categorized into 4, patient A, B, C, and D. Let's start with the most severe. If the patient is high risk, meaning the patient has comorbidities and they have more symptoms, the first choice given is a LAMA plus LABA. I recommend for escalation, we may use LAMA plus LABA plus we now include ICS. We may also consider roflumilast if FEV1 is less than 50%. For patients who are high risk but fewer symptoms, our first choice is a LAMA. If it becomes worse, we can give a LAMA plus LABA or LABA plus ICS. For category B, low risk with more symptoms, meaning the patient has no comorbidities but they have more symptoms, we can give a LABA or a LAMA. So the difference here, for the patient D, you both give a LAMA and the LABA. So for escalation, for patient B, we give LAMA and LABA. For patient A, low risk with fewer symptoms, we can give a SABA or a LABA or a SAMA or a LAMA. Okay, for COPD exacerbations, what we need to take note is that as compared to asthma, there is a routine use of antibiotics for patients with COPD because COPD patients are more prone to infection. So prevention strategies include daily ICS for those with frequent exacerbations. Now, question, can metoprolol be used in COPD management? We know that metoprolol is beta 2 receptor agonist, right? So according to the Katsung book, Innovative Approaches, it says that the hypothesis that B1 receptor antagonist treatment such as metoprolol is beta-1 receptor specific. I got confused on that. So your beta-1 receptor antagonist, metoprolol, may reduce exacerbations of COPD. Traditionally, when we talk about beta receptor antagonists, though metoprolol is specific for beta-1, there are still observed effects in beta-2 inhibition. So it reduces your beta-1 receptor antagonist reduces mortality from cardiovascular diseases. So right now, a prospective study is being done to check the effects of metoprolol on COPD patients at risk for exacerbations. Okay, the next slides actually show us available drugs under the different categories. For example, SABA, we have your albuterol, bitalterol, ephedrine, epinephrine, levalbuterol, metaproterenol, purbuterol, and terbutaline. For your SAMA, we have ipratropium. For your combination short-acting bronchodilator, you have your albuterol, ipratropium, or your combivent. For your LABA, you have formoterol, indacaterol, olodaterol, salmeterol. For LAMA, aclidinium, tiotropium, and umeclidinium. There are also aerosol corticosteroids in the form of beclomethasone, budesonide, cyclesonide, mometasone, flunisolide, fluticasone, and triamcinolone. Now, we have combination inhalers. When I say formoterol, budesonide, what is this? A combination of what? LABA and ICS. Formoterol and mometasone. LABA and ICS. Salmeterol and fluticasone. LABA and ICS. Binlanterol and fluticasone. LABA and ICS. Bilanterol and umeclidinium. This is LABA and LAMA. Under the drug category, leukotriene inhibitors, we have montelukast, zafirlukast, zileuton. For phosphodiesterase inhibitors, your methylxanthines, you have diphyline, roflumilast, theophylline. For monoclonal antibodies, we have omalizumab, pembrolizumab, mepolizumab, and restizumab. Okay, that ends my discussion on drugs used for asthma and COPD. Do you have any questions?
Ask lang po.
Yes.
Regarding dun sa mga xanthine products, ina-accept pa rin pa yung doxophilin? Ginagamit pa rin ba siya?
Not
For COPD?
Actually, there are still those who use doxophilin for treatment of COPD, particularly those with frequent exacerbations. Yes.
Thank you, Doc.
Okay po. Yes, Sir Erwin, you're raising your hand.
Dra, good evening, Dra.
Good evening po.
Dra, kasi I am a community nurse. Kasi may na-encounter ako sa community na almost 3 years na siyang nagme-maintenance ng salmeterol plus fluticasone, yung Adiflo po. Tapos, sinasabayan po niya ng salbutamol plus ipratropium. Is it possible na may ganun katagal? Almost 3 years na nagme-maintenance. Pero ang case po ng patient, Doc, is COPD.
COPD.
Opo.
It's being given salmeterol and fluticasone.
Opo.
Yun nga, di ba pagbabalikan natin yung treatment ng COPD earlier. So, salmeterol and fluticasone is a LABA with ICS, correct? So, actually, meron kasi tayong tinatawag na exacerbation. So, yung short-acting, yung sabi mo salbutamol plus ipratropium, they may use it for exacerbation. So, if they have the attacks, yun ang gagamitin talaga natin, no? SABA. 2 to 3 acute attacks. Your LABA plus ICS, they are actually controllers, meaning we prevent the exacerbations by taking this. And yung tanong mo na may ganun ba talaga katagal, take note that COPD is a progressive disorder. unlike asthma, it is not fully reversible. Therefore, we recognize the need for controllers to prevent exacerbations. Kasi kung hindi natin yan i-treat at i-prevent yung exacerbation, tayong tinatawag
Okay. Thank you, Budra.
Alright. Lian? Sir Lian Sanchez?
Doc Nika, yes po. Doc Nika, about administration, kasi dati usually na-encounter ko yung salbutamol and ipratropium na bibigay together. Wala pa po yata nun na, or wala kami nung combine niya. Paano niyo po ibibigay yung pareho? Pwede po bang election pareho or salbutamol first or ipratropium first?
Actually, meron na sir pong available yung salbutamol ipratropium, yung Compifen.
Ako, Doctor. Paano po kung wala po? Available lang po sa atin.
Okay. Meron siyang milligrams po, sir. So, if we try to check on the dosage, meron naman tayong mga meron pong recommended na dosage. So, sometimes depending on the case, but mag-check lang po tayo nung recommended na dosage together.
Tapos, doktor, na dun sa may nebulizer, pwede ko bang paghaluin siya? Yung ipratropium sa salbutamol kung separate ang meron ako? Or bigay ko salbutamol first, then
It can be used together, sir.
Okay.
Opo. Thank you. And okay po. I think no one's raising their hands anymore. So these are my reference. We have Cat Zoom. I also used Sleeping Cot and USMLE. Okay. So let me end this presentation by saying that life does not get easier, you just get stronger. So siguro magkakaedad lang din po tayo, or maybe some of you are younger than me or older than me, but you have already experienced this and I think you agree. We just get stronger. So may konting hugot lang po tayo while ending this class. So thank you so much my lecture, not this class. So I'd like to thank everyone for your attention. So let me stop sharing. So now it's 7 p.m. We still have 1 hour and 30 minutes. We can continue with the discussion. So I'd like to ask any volunteer for the next presentation. Walang volunteer. Okay, let me just check.
Hello, Dr.
Yes, you want to volunteer?
Doc, this is Joseph from Vegan Group. I just want to ask some of my group mates kasi we're ready but unfortunately yung mga ibang group ko at nagkakaroon ng technical problem for the Wi-Fi.
Mm-hmm.
I love that you, Doc, if ever.
Okay, thank you, Sir Joseph. Anyone else who would like to volunteer? Because if not, I will be forced to call a group, particularly those who are not done yet. And by the way, I'd like